We are Group 5 and did our biomechanical analysis on the usage of a wheelchair with and without trunk lean, as well as between two participants of different heights. To begin our analysis, we selected two subjects. Participant 1 is 5'5" and participant 2 is 5'11". The participants were asked to perform wheelchair propulsion for a distance of 40 feet. One trial was completed with trunk usage and one trial was completed with full back support to the chair. We recorded the movement of each individual, compare, and analyze it by breaking it down into 5 different phases: pre-drive, initial drive, mid-drive, terminal drive, and recharge phase. Additionally, we assign an activity level to each muscles involved. And now we're going into the pre-drive phase. Pre-drive phase is the starting point of wheelchair propulsion. In both techniques, with and without trunk movement, the back is flat against the chair, while the arms are cocked back and ready to initiate movement. This is a static phase. All of our muscles are working isometrically to maintain position. The shoulder joint is mainly an extension with some abduction and internal rotation. Posterior deltoid and latissimus dorsi are primarily responsible for this action. Biceps brachii holds elbow in flexion, while flexor and extensor carpi ulnaris situate wrist in ulnar deviation. When comparing the movements performed by the two participants, we observed some compensatory changes in participant 1. We noted increased shoulder abduction, shoulder extension, and elbow flexion as compared to participant 2. We suspected that these are necessary adjustments for a lesser height. There are no changes in trunk position during this phase. Please refer to the following chart for a further description of the orthokinematics and muscle involvement at each joint. Initial drive phase. During initial drive, we are progressing from a static position to a dynamic movement. This is the second phase of the wheelchair propulsion sequence. In this phase, the shoulder is going to initiate flexion while maintaining abduction and internal rotation. The muscles of the shoulders are contracting concentrically, with the anterior deltoids and pec majors found to be the most active. The concentric contraction of the triceps extends the elbow. The wrist maintains ulnar deviation and adapts to the shape of the wheel. Once again, flexor and extensor carpi ulnaris are responsible for this action. Trunk lean during this phase is supported by eccentric contraction of the back extensors. When making comparison between the participants, we notice that participant 1 maintains greater shoulder abduction, shoulder extension, and elbow flexion. As previously mentioned, we suspect these to be compensatory actions for a lesser height. There was not enough trunk flexion to warrant noticeable changes in body position for both subjects. Please refer to the following chart for a further description of the orthokinematics and muscle involvement at each joint. Mid-drive phase. Mid-drive phase precedes initial drive and has many similarities. Shoulder flexion, elbow extension, and wrist ulnar deviation progress further into their movement respectively. Participant 1 maintains her increased shoulder abduction and elbow flexion. Please refer to the following chart for a further description of the orthokinematics and muscle involvement at each joint. Terminal drive phase. Terminal drive ensues mid-drive and is the fourth phase of the wheelchair sequence. Biomechanically, there are many similarities between terminal drive and the previous two phases. At this phase, with and without trunk lean, we are at the end of propulsion, where the involved muscles are at their maximal activity. Please refer to the following chart for a further description of the orthokinematics and muscle involvement at each joint. Recharge phase. Recharge phase is the intermittent period in which the participants revert from terminal drive back to pre-drive and initiate the cycle all over again. There is movement and muscle action at the shoulder, elbow, and wrist going the opposite direction of the previous phases. The shoulder is returning into extension, abduction, and internal rotation. Elbow flexion is restored while wrist ulnar deviation returns to the initial position. At this phase, initial postures are restored for both participants. Participant 1 assumes her additional shoulder abduction, shoulder extension, and elbow flexion as compared to participant 2. Please refer to the following chart for a further description of the orthokinematics and muscle involvement at each joint. In conclusion, the variations of movement prove different outcomes. One of the main differences between the two subjects being the additional shoulder abduction and internal rotation seen in participant 1's movement. We believe that her lesser height had a major influence in her assumed posture. Furthermore, we conclude that her movement was less efficient, which is supported by our 40 yards wheelchair propulsion test. There are many limitations in our research, which include the lack of an EMG to measure muscle activities, dynamometer to measure strength, and customized wheelchairs. Although we were unable to use an EMG to record differences in muscle activities during each wheelchair sequence, we were able to determine their actions through palpation. As for the wheelchair, we used a standard one. Lastly, in the future, we hope to conduct further studies with proper equipment and contribute to the medical field.